Why is bypass failure so complex to treat?
Failure is a really complex situation, a really distressing situation for every vascular surgeon, above all in patients with CLTI. In literature, there are not so many papers evaluating the clinical outcomes in this type of patient because in some publication authors consider together intermittent claudication and critical limb ischemia, and then the result, the data are a bit confusing. But in case of critical limb ischemia and bypass failure, in this case, the bypass failure is really dangerous for life and for limb, and because it is related with high rate of mortality and high rate of limb loss, and this range between 50 and 75% at 2 years.
What are the different treatment options, and why do you choose Rotarex when taking an endovascular approach?
When we treat this really complex patient, we can choose between some different treatment. We can use, of course, open surgery, we can use local thrombolysis, or eventually we can use mechanical arteriothrombectomy devices and then Rotarex S. Considering open surgery, of course, keeping out the Fogarty thromboembolectomy due to the non-acceptable result, open surgery is based on the redo bypass surgery, but we know well that redo bypass surgery, above all in patients with many previous revascularization, is really complex, really distressing for every vascular surgeon, and also redo bypass surgery is has pure long-term results in case of not available autologous vein for a new bypass. Therefore, and also based on the 19th trials, local thrombolysis has become an alternative treatment for this type of patient, but local thrombolysis is too slow to restore the flow in case of a really acute ischemia, and also is not effective in case of subacute or chronic bypass occlusion. This is the reason why we have started to use Rotarex S in this type of patient, because in this device the combination of a rotating helix and a rotating head, a rotating tip of the catheter allows the detachment or the removal of every thrombotic material, then acute, subacute and chronic. And then using Rotarex S we are able to perform to obtain a flow, very quickly flow restoration without use of lytic agent.
What is the aim of your study published on VASA?
We published a paper on VASA focused on evaluating the effectiveness, the clinical effectiveness of Rotarex S in patients with CLTI and bypass failure. The purpose, the aim of this study is to compare between open surgery and mechanical arteriothrombectomy devices in patients with acute, subacute and chronic bypass occlusion, and considering not only the clinical outcomes but also the treatment costs.
Can you describe the clinical results and the treatment cost evaluation?
In our paper, we analyzed a continuous series of 48 occluded bypass, 17 treated with open surgery and 31 treated with Rotarex S. These two groups of patients are completely homogeneous considering the demographic characteristics, the comorbidities, and all patients are with CLTI, then from Rutherford 4 to Rutherford 6, most of them in Rutherford 5 class than with a tissue loss into the foot. And another important thing is that more than 70% of these patients have a subacute or chronic occlusion and then not suitable for local thrombolysis. Regarding the treatment, there are three significant differences between open surgery and Rotarex S. The first one is the duration of operation that is about the half in the Rotarex group. The blood transfusion are significantly lower in the Rotarex group. And finally, considering the length of hospitalization, this is about 1/3 in the Rotarex group. During follow-up, no differences in death rate, in reocclusion rate, and in limb salvage rate. The only significant difference is considering the reocclusion time. This is longer after Rotarex procedure than open surgery. The second part of our paper is dedicated to the cost evaluation, and this in this cost evaluation, if we consider separately the intraoperative and the perioperative period, in the intraoperative period, the Rotarex procedure is more expensive than open surgery, and this is due to the Rotarex cost, due to the other endovascular material costs. But if we consider the perioperative period, the Rotarex procedure is significantly less expensive than open surgery. And then in this paper we apply also the cost effectiveness analysis, then the ratio with the cost of health gain and the gain in health, and then due to the longer patency after Rotarex and the lower cost, Rotarex seems to be a dominant therapy. This is the final result of our paper.
What is the take-home message?
Experience, and based also on the result of our paper published on VASA, Rotarex, the mechanical arteriothrombectomy device, is a safe device in patient with an effective device in patient with bypass failure and CLTI, and of course is less invasive than open surgery, but is also less time consuming and also less expensive, producing a greater health benefit with a longer reocclusion time. And then now the Rotarex, in our experience, is a first choice treatment because this is a dominant therapy.